Good morning, everyone. I have 10 o'clock, and so we'll begin the webinar presentation. So glad you all were able to join us today to learn some more about rural health and hospital-based billing during and after the COVID pandemic event. The presentations for today were sent out yesterday around 5:20 in the evening, if you'd like to pull those up for reference. Today's session will be recorded. I do want to thank Ellie Orwig with the Indiana Rural Health Association for supporting Zoom in the background and addressing any issues that individuals are having. You will be muted during the presentation to cut down on the background noise. You can unmute your line by clicking the telephone icon beside your name in the participant column. And we do encourage you to chat any questions that you have in, or you can feel free to unmute your line and ask questions. Also want to thank Joyce Fillenworth, David Conrad, and Nan Alley at the State Office of Rural Health for all of their support and assistance. I do want to share that unfortunately Sharon Shover from the Indiana Hospital Association will not be able to join us today due to something unexpected that came up, but Elizabeth Burrows is going to be presenting in her place today, so we really appreciate Elizabeth jumping in and covering for Sharon this morning on the webinar. Also with us is Elizabeth Killian, and Elizabeth is the Providers Relation Manager at FSSA, and she will be sharing billing information from a Medicaid perspective. At this time, though, I would like to turn it over to Allie Orwig so that she can remind you and share with you some information on an FCC grant available. So Allie, if you'd like to share.
Thanks, Becky. So there has been $200 million released by the FCC to address the COVID-19 pandemic through the use of telehealth. It is first come, first serve, so there is an element of time sensitiveness to it. If you want to apply, we suggest you probably should be moving on that sooner rather than later. It is retroactive back to March 13th, I believe. So even if you have already enacted some of these services, you may still be eligible for funding. It is only available to nonprofit or public health entities. I have had some questions come in from some for-profit entities that thought they would be eligible, but that is not the case. So you do have to be nonprofit or public to be eligible for funding. It does differ from the Healthcare Connect Fund, which many of you are familiar with, in that there are many more services, hardware, software, etc., that are eligible for funding. And also it is covering 100% of the costs. So if you've implemented anything to do with telehealth to address the COVID-19 pandemic, certainly this is a program worth looking into. If you have participated in the Healthcare Connect Fund, you are already a leg up on others because you will already have some of the information in the FCC's system that you'll need. Definitely reach out though. If you have any questions, you can reach out to myself at aorwig@indianarha.org. That's aorwig@indianarha.org. Or I know there are tons of other resources. I know Elizabeth and folks at the state are happy to help out as well. So again, it is first come, first serve. Probably there's a little bit of contradictory language in the order, but we know they're already approving some funding requests at the FCC, so the money is going out the door already. Again, if you have questions, please reach out at any time, but I think that covers most of it.
Thank you, Allie. So at this time then, I'll turn it over to Elizabeth Burrows. I believe most of you know Elizabeth. She does a lot of consulting for the state and really is an expert in this particular area and a good substitute for Sharon today. So Elizabeth, I'll turn it over to you.
Thanks, Becky. Well, again, you have a substitute teacher today, so please bear with me. I also want to say that Sharon is going to be available, that you're welcome to email her. Because of some unknown circumstances, we ask that you would CC myself or Shelby Hornback or Becky Royer so we can make sure those get answered. We're not for sure how long she's going to be out. So just CC all of us. But again, I think all of you have those emails. I'll ask Shelby to type those in the chat so you have them to make sure. So if you did not receive this presentation, or if you need additional information or have questions, again, you can feel free to email Sharon, but we ask that you CC one of us as well so we can ensure a quick response. We're excited about the great turnout today. And again, I do want to emphasize thank you to Joyce, David, and Ann at Indiana State Department of Health and their Office of Rural Health and Primary Care for their never-ending support of what we do. So start off, there's confusion, and some of you may have heard presentations in the past that define telehealth versus telemedicine. We are going by the most recent guidance that was put out last Friday by CMS, Center for Medicaid and Medicare Services. So, I will say Medicare defines things a little bit different than the state when we hear from the other Elizabeth, Miss Elizabeth Killian. So there are some differences, and we just all have to work through these. So again, telehealth services require the use of an interactive audio and video telecommunication system. So it's real-time communication between the provider at a distant site and the patient at the originating site. So there used to be restricted site, removes the site restriction, so the patient can be located at home. This is very important because this is something I've been asked a lot. So you can be providing services with the patient at home and still get your full RHC or provider-based reimbursement rate. Restricted distance sites. During the emergency, CMS allows RHCs or FQHCs to be a distance site. CMS clarifies that practitioners can provide telehealth services from their home, but they have to be working for that facility. So that's another question I know I fielded a couple of times. Yes, and that's for primary and behavioral health care. So you guys can be working at home, the practitioner can, and provide telehealth during this emergency. CMS also lifted the requirement that a qualifying provider be licensed in the state where services are rendered. They still have to be licensed, but not in that particular state. And it decreased the provider enrollment rules. Medicare telehealth, written consent must be on file prior to treating the patient. And there are a lot of special guidances around consent. There's a lot of samples. If you go on the cms.gov website, you can really get some good samples. The consent has to be obtained by the staff of the RHC or the provider-based clinic. Again, it can be verbally or it can be written. And there's a lot of ways people are doing this, I've heard, but again, make sure that gets documented in the chart. Verbal consent, though, is fine. And CMS will allow new or established patients to receive services. So before it was only existing, now anyone can get your services. Now, some more changes here. All the rules that were once rules are now different. So you used to have a two-way real-time encounter with audio-visual services. However, during this time, CMS allows non-telehealth services through telephone and online digital services. So yes, I know some of you have called me, oh, we're trying to get our annual wellness visits. The only way the patient can hear us is by phone. Yes, that's allowed now during the emergency. Also make sure that you do denote in the chart this all happened during the pandemic emergency. Just for extra clarification. Yes, you can look back at dates, but again, document that consent, document that it is during the pandemic. CMS has determined the list of services eligible for telehealth, and there's a lot of added additional services that can be found. We're not going to go there right now, but on your slide, you can click into that hyperlink and you can go there. So they have expanded the list, and they used to always require cost sharing for telehealth services, but right now during the emergency, which is why it's important to note that in the chart, providers can choose to waive or reduce the cost share for telehealth services. COVID-related visits must require a CS modifier, and Medicare will pay at 100%. So there's definitely no cost sharing there. Modifiers, it's all of our billing team's favorite word. So these are some modifiers that can help you get through. Place of service or telehealth visit is a modifier 02. If you have real time via audio and video, it's 95. Store and forward, which we really haven't talked much about, but I don't think it's going to be used a lot. It's a lot of times where you take a picture of a dermatological issue and send it, have somebody review it, it comes back, or maybe a radiology visit. That requires the GQ. Face-to-face encounter with audio and video telecommunication, which is probably going to be one of the most popular, and that's a GT. Cost sharing for COVID-19 testing and visits is a CS. And during the emergency, POS is equal to what it would have been if performed in person. So the point of service, contact, place of service, it's the same as if it was in person. Some changes that have went into effect. Effective March 1st of this year, Medicare will pay 100% of the RHC rate for telehealth services related to COVID-19. RHCs must place the CS modifier on the service line related to COVID-19 service. Initially, the claims will process with coinsurance, but will be automatically reprocessed in July. And there's a lot of questions probably about this specific thing. I know I was talking to the National Association of Rural Health Clinics just this very week, and they said they're still trying to get additional information and the details about all the reprocessing.
Hey Elizabeth, this is Shelby. Since you're on this slide, I want to go ahead, since you said there is some confusion, but can you just identify that difference between that CS modifier and the CR modifier? Do you know that off the top of your head?
I wish Sharon were here right now. So again, you have the substitute. The CS is what I'm being told, and that's what all came out in these recent, during the emergency modifiers that came out, is to use the CS modifier. The CR modifier, if you can tell me when you think you should use it, I can talk through it, but I cannot speak exactly when the CR modifier should be used. So everything I've seen and the presentation I've witnessed have all said the CS. That's something that Becky, myself, and Shelby can work to get you a more definitive answer and email that out for clarity.
Elizabeth, there's also another question. Is this modifier 95 or POS 95? And CG modifier and CS modifier, or just one?
What I have seen is the CS modifier supersedes everything. So they're going to see that. The CS modifier is what's to alert them to COVID. So I would use that. For safety, I would use the POS 95. So you have place of service. Again, if it bounces back, you know to take that off. But personally, I would be safe. I would put both of them on there. So that's 2/3 of the question, Becky. And I can't remember the other third. I'm sorry.
The entire, and there was just some addition here. The entire question is this modifier 95 or POS 95?
That's
CG
POS
modifier and okay, and then CG modifier and CS modifier, or just one? So no, usually CG for rural health clinic can't put two POS modifiers
I'm with
on a
you
claim.
now that you're right. Now that I'm thinking of it, I would put both. You know, with Indiana Medicaid, I put the T1015 with it. So yeah, I would probably do your CG and your CS. Again, you want to make sure that you're going to get that RHC rate. The CG modifier is the only thing that's going to guarantee that for you. There also are some new guidances that are coming out about how your cost report's going to change. Not to scare everybody, but there's some certain things related to COVID that's going to be different on your cost report. So you're going to want to make sure, if there not just, I mean, you can use the CG modifier to indicate your rural health clinic, but I would definitely include that CS modifier because you may need to pull that out later for your Medicare cost report at the end of the year. I just got that late last night, an email about that, the changes they're making. Any other questions? And if
No
somebody
other questions
else knows,
at this.
I would say if somebody else knows on the call, type into the chat, because again, you guys are the ones that are submitting claims all the time daily and getting your payments back. So I know I have some big experts on the calls. I'm not going to call you out because there's a lot of people on here. But if you guys, some of you that are big experts, billing experts that send me questions all the time, Cameron, Pulaski, Putnam, just to name a few, feel free, if you guys know an answer and you've submitted claims, tell us, because again, you're the ones that know.
And all of the questions that do come in when we send out the recording to the event, we'll also answer these questions and add any additional detail. So, okay, Elizabeth.
Thank you. And again, I apologize for being the substitute today. Documentation requirements, you do need your consent for treatment. Again, can be verbal. Advise the patient that your deductibles will apply. Again, that can change if you know that your organization is going to waive that cost sharing. So that's something that your practitioners need to know from the administration and your billing department. The location of the patient and location of the practitioner, specific details discussed, observed, and advised, and number of minutes. And one thing not on here, but I would put on there, is to make sure they understand that's during the emergency pandemic. Okay, what is the difference? So this is where Medicare and Medicaid diverge. So audio only telephone call, that's a virtual check-in. There's your CPT code, your codes. I'm not going to read those to you. During an emergency, RHCs use the code G0071. It must be at least 5 minutes. If you've been on a visit, like I have this, I know a lot of places are doing the virtual check-in. A nurse comes on, goes through all your check-in, then you go to the provider. For those of you, a lot of you using DoxyMe that you've told me that it's kind of set up that way already. And I know other telehealth platforms, that's just one that I've personally used. Audio and video is your telehealth visit. Use your E&M categories of codes, use the 95 modifier. And during an emergency, you know, Skype, FaceTime, they don't enforce the privacy requirements. Now there's new things coming out about that daily too with the HIPAA and what you can use. That's a whole topic for a whole nother call. Online only is e-visits. There's your CPT codes, your G codes, and then RHCs can use the code G0071 during this time. When we say RHCs, that also includes your provider-based clinics. G0071 requires that a patient be seen in the last 12 months. However, here's the changes. COVID-19 pandemic allows it can be a new patient. You don't need to be seen in the last 12 months. Consent can be obtained at the time of service, and consent can be obtained by staff under the general supervision of the RHC practitioner. A lot of times that happens during that virtual check-in. You know, you have a nurse or an MA get all the consents and everything. Virtual check-in or virtual care communication, brief communication with the patient, remote evaluation of a picture. This is how you bill. It can happen once every 7 days, and this is your payment. It's $24.76. Medical discussion or remote evaluation of a condition not related to an RHC service within the previous 7 days and does not lead to an RHC visit within the next 24 hours. So if you have that communication, you say we need a visit, you know, let's schedule a visit for, you know, tomorrow, then you cannot bill for this. I believe this virtual check-in has been in place for a while, but been utilized very little before the pandemic. Telehealth visits.
And Elizabeth?
Yes.
Elizabeth, this is Becky, and you might take a look at the chat. There's some comments about clarifying 95 is not a modifier, not a POS.
Well, we will just have, it's not a point of service. Is that what they're, place of service? If somebody knows again on the call, tell me, but I would have to research this. I don't want to say the wrong thing. I'm going by Sharon's slides here. So she's saying use modifier 95 on these telehealth visits. And if you guys are saying that's not going to work, then we'll definitely do some additional research. If somebody has the answer, if you can put it in the chat or alert us, we would love that.
It looks like most are saying that 95 is a modifier, not a point of service.
Okay, perfect. There we go. Sorry, I said the wrong thing, then I misspoke. So use the modifier 95 on these visits. And again, for your distance site, you're going to get $92 per telehealth service visit. The $92 is something that if you were on the call on Wednesday, they talked about they're working, National Association of Rural Health Clinics is working to get that raised. But right now you do not get your full Medicare rate for telehealth. You only get $92, whether you're independent, provider based, or whatever kind of RHC you are. So I apologize, modifier 95, not POS 95. Digital e-visits, this is patient initiates them. You're managing various services. Here's your information on how to bill and your reimbursement. I'm trying to make sure to give Elizabeth Killian plenty of time. So telehealth visits do not technically count as RHC visits. If they are furnished between January 27th and 30th, they'll be reimbursed at your all-inclusive rate. You must apply modifier 95 on the claim through June 30th. You're going to ask if that's going to get extended. It potentially can, but at this point it's not. Telehealth services are provided on or after July 1. RHCs will use a specific G code for telehealth. You'll be reimbursed at the rate of $92, and claims from January to June will be reprocessed in July automatically by the MAC. CMS will recoup the difference. So again, that's something you're going to have to babysit and follow up on. Okay, I think we are back on time, maybe a minute or two behind, and I can turn it back over to Becky and Elizabeth Killian.
Thanks. Thank you, Elizabeth. We appreciate you pinch hitting here during these very fluid times. So at this time, we'll have Elizabeth Killian share her presentation. Elizabeth, again, is the Provider Relations Manager at FSSA, and it really does a nice job of sharing information in a very understandable manner. Again, please chat any questions in that you have, and we sure appreciate others chiming in and providing clarifications. If you have anything that you would like to add in the chat, you believe others would find helpful, we encourage you to do so. We want all of the clinics to be reimbursed at a maximum potential as possible. So Elizabeth, I will turn it over to you.
Thank you. So I will be going over Medicaid's telemedicine policy. A lot of it will be quite similar to what the other Elizabeth just said in reference to Medicare, but there are some pretty specific differences as well. So just something to keep in mind there. For some reason, there we go. So the first thing, as Elizabeth Burrows said, Indiana Medicaid does differentiate between the terms telemedicine and telehealth. Telehealth is the remote monitoring of clinical data through technological equipment in the member's home, and it is specific to home health. So if outside of any other type of services, telehealth, that term for Indiana Medicaid does not apply. For telemedicine is the use of video conferencing equipment to allow a medical provider to render an exam or other service to a patient at a distant location. The distant site is the location of the provider, and the originating site is the location of the member. Through the duration of the governor's public health emergency for the COVID-19, IHCP will allow reimbursement for most services delivered through telemedicine. The ones that are excluded are the ones that are listed here on your screen. Essentially, if it is absolutely necessary that member and provider be in the same location, for example, a surgery, then obviously that cannot be billed via telemedicine. Any other service where it is not, the member and the provider does not actually have to be in physical contact with the member, then those services can be provided via telemedicine. The confusing part comes a bit in the billing, as there are two different ways to bill. We'll get to that in just a moment. The technology must provide real-time interactive consultation between a provider and a patient. You can use computers, telephones, and television monitors. In most cases, you can use either audio only or audio visual. Cannot use emails or text messages. And the governor's executive order 20-13 did indicate that any physical therapy, speech therapy, or occupational therapy must have a visual component and cannot be audio only. Similar to Medicare documentation requirements, we do need the appropriate consent from the member, which again can be provided verbally. And you also need to indicate the services rendered via telemedicine and the location of both the provider and the member. And similar to what Elizabeth said, we want to make sure that you document in the member's file that the services were provided via telemedicine, just in case there's any audit questions later on moving forward. So this is where we get into the differentiation between our standard telemedicine and telemedicine during COVID-19. When the service is on the telemedicine code set, you would continue to use those procedure codes from the telemedicine code set, and just as Elizabeth said, use the place of service code 02 and the modifier 95. And that should be relatively straightforward. And this is actually our standard telemedicine policy. So that would be the same regardless of during COVID or not during COVID. If a service is not on the telemedicine code set, we're trying to make it as easy as possible. You would use the same procedure code that you would use as if you were providing this service in person in their standard setting. However, you would want to include a place of service code that most appropriately reflects where the member is located. And then, if possible, however not required, include the GT modifier. And we say if possible, but not required. So if you are already including 4 modifiers, then you have hit the limit of how many modifiers are able to be included on the claim, and you would not be able to include GT. So that is fine. It's not going to cause a denial. But we do want you to include that if possible, if you're not using the full spectrum of the modifiers available. And so if this is a procedure code that is not on a telemedicine code set, we do not need you to bill with the place of service code 02 and modifier 95. That would actually cause a denial. So for the distance site, if it is on the telemedicine code set, you use the procedure code from that code set, modifier 95, place of service 02. If it's not on the telemedicine code set, you use the standard procedure code with modifier GT and whatever the appropriate place of service for the member's location. For the originating site, a member location, if this is a professional claim, you could use procedure code Q3014, modifier 95, revenue code would not be included. An institutional claim, same procedure code, same modifier, and then revenue code would be 780 for telemedicine general. Again, want to remind, providers are not allowed to bill for an originating site fee when members utilize telemedicine from their homes. And then we do have specific FQHC billing instructions. So regardless if the same procedure code is both on the telemedicine code set and not on the telemedicine code set, you would use the T1015 or the T1015 with another IHCP covered code. Your place of service, if it is on the telemedicine code set, you would use the O2. If it is not, you would use the most appropriate place of service code, but not use O2. And then depending, again, if it's on the telemedicine code set, use modifier 95. If it is not, then you use GT. We've had quite a few questions about this for FQHC specifically. I will reference some additional resources at the end that you can use if you have further questions on that. This is just another example of how to bill for FQHC specifically. And then for school-specific billing questions, again, mostly pretty similar, except that for the modifier, you are going to add the TM modifier to indicate that it was school-specific. But for the most part, you want to use the appropriate procedure code from either the telemedicine code set or not the telemedicine code set. The appropriate place of service, same rules apply. If it is on the telemedicine code set, you use the O2. If it is not, you use whatever is appropriate, but not O2. Modifier 95 for telemedicine, GT for non-telemedicine, and then again, throw on that TM. So these are some preliminary telemedicine questions that we have received so far that we wanted to address. What is the reimbursement rate for telemedicine services? The services will be reimbursed at their standard fee schedule rate. So this is mostly for the procedure codes that are not on the telemedicine code set. We are not changing reimbursement rates at all. You'll be reimbursed at the exact same rate as if you had provided that service in person. Are there geographic limitations? No, there are no geographic limitations, and there are no limitations on the location of either the provider or the member. Both the provider and the member may be in their home to provide or receive services. Is there any limitation on the technology that can be used? Again, this is similar to what Elizabeth was saying. Currently, the technology does not need to be HIPAA compliant at this time during the public health emergency. As I mentioned before, emails and text messages are not allowed. And then again, with the PTO-TST, there must be a visual component. Does this guidance apply to all IHCP programs? Yes, this all applies to both traditional Medicaid or fee-for-service, as well as all of the managed care programs. And the managed care programs are actually following all of FSSA's current, not just telemedicine, any policies that we have put out specifically for the COVID-19 public health emergency. MCEs are following all of those same guidance that we have put out. There is limited benefit packages such as Package E that allow telemedicine if the procedure code being billed is covered under the member's plan. So in those types of situations, you do want to make sure that it is covered generally speaking, and there may be specific billing guidance, like such as Package E. That all still applies, but if it's covered under the benefit plan, it will still be covered now. Can ABA therapy be performed through telemedicine? Yes. And can physical therapy be performed through telemedicine? Again, yes, but there must be a video component. We are not allowing teledentistry to be performed through telemedicine at this time. So that is one service area that we are not permitting through telemedicine. But yes, MRO services can be allowed and covered through telemedicine. I'm looking for specific guidance around license requirements, supervision, or other concerns for telemedicine. So this is where we have gotten a lot of very specific questions about can this service or that service or whatever this type of license be used with telemedicine. as long as providers are acting within the scope of their licensure, the IHCP is allowing and encouraging telemedicine as much as possible. So we ask the providers to use their professional discretion. Again, if it is reasonably able to be provided via telemedicine with like those services I initially mentioned at the beginning, you don't have to physically be in the same room as the member to perform and provide that service. Then for the most part, as long as you are following the scope of practice that is allowed within your licensure, we are allowing those services to be provided via telemedicine at this time. What other resources are available? We recommend always reaching out to your regional field consultants for either DXC or your MCEs, provider reference materials such as the banners, bulletins, and the provider reference modules on the IHCP provider website, and of course the provider education. IHCP has been doing nearly weekly webinars at this point. We actually were not able to get one scheduled for this week, but I think we've done about at least 3 to 4, if not more than that, in a row each week since this public health emergency has started. If you go to the provider education tab on the provider website and then go to IHCP Live, all of those webinars are listed there, and there's a ton of information outside of just telemedicine. If you're not receiving our banners and bulletins in your email each week, we recommend going to the provider website, scrolling all the way to the bottom, and you'll see this green box where you can enter your email address and sign up to get those directly into your inbox each week. Highly recommend that always, but specifically right now, as we have probably put out more than 20 bulletins at this point, clarifying and introducing new policies. And then, of course, how can we help you? Always be sure to reach out to your provider relations field representatives for either DXC or the MCEs first. But if you have exhausted those resources and still have not gotten responses that fulfill your request, you can always reach out to the provider relations team with OMPP at that email address on your screen. And so that would be for individual provider concerns. And then also our IHCP Listens email. If you have any feedback on the way that we are communicating with providers, if you think that there is a better way for us to engage with providers, if you have ideas for future presentations or workshops or questions to be answered in future publications, feel free to email us there. I always think of it this way. If your question is probably specific to you or your office, you probably want to email the provider relations inbox. If the answer is something that could potentially assist everybody in your provider specialty or the whole provider community altogether, that would probably go to the IHCP Listens. However, we do say there is no wrong door, so regardless of where you send a question, we will get that answered for you. As I alluded to, there are many banners and bulletins that have come out about COVID and IHCP's response. So please check out the banners and bulletins pages on the provider website. We also did at least one, I think 2 now, telemedicine FAQ documents that are also available on the website, which are responses to questions that, this is actually a presentation that Provider Services Director Michael Cook gave previously. So questions that we got in response to this presentation, and then other presentations we have given moving forward. And it's just an FAQ document with responses there. So if you have any questions, please check those out, although obviously I can answer questions now as well. And I saw that like the questions were kind of popping up here in the chat, but I couldn't see them as I was presenting, so I'm not sure how to see them now.
I was not seeing any additional questions. Shelby, do you have any on your end? There may have been some that came to you.
Yeah, no, Elizabeth,
privately.
Some chatter going around about that modifier and POS, and Elizabeth Burrows helped, but a lot of people on the call were providing their insight, which has been really helpful. So I don't think there's any new questions.
Okay, great. Maybe it was just something odd that I was doing to make that line pop up. Are there any questions that I can address for anybody?
You're welcome to chat them in or unmute your line. Or if you'd like to unmute and share any experiences or feedback that you would like to share with the group in general. Not seeing any additional questions at this time. Elizabeth, Burrows, anything else that you would like to share?
No, I don't have anything. Thank you for all your assistance in helping me. I love the biller community. You guys are definitely the experts. I would, since we have a couple of minutes though, how is this working for anybody? I mean, is anybody actually getting paid for providing telehealth services, and are you having success with that? I think that would really help people. We have had a couple questions come in. What happens with every insurer? We get volumes of information that is really not needed, and we have to spend time searching for the needed info and the webinar. So I'm not for sure what happens with every private insurer, maybe they're asking. Not a question, just a statement, sorry. And then doing high risk preventive education for COVID at all via telehealth. And Elizabeth, maybe you can help on this versus me, but, or I want you billers to step in. We have studies saying they're still confused regarding the modifier CR versus CS. Can you provide more information? And since I'm the substitute, I can't do it now without additional research. If someone on here knows the answer, please step in.
And again, we'll have that information for you when we send out the recording too. But it would be great to clarify that while we're on the call.
I would need to do more research as well. I don't have an answer for that one currently.
I know Ashley and I think some others were on the NARC call. If there was anything good about that you guys have information, please unmute yourself and share, or write in the chat box would be great. Otherwise, we will definitely get it clarified.
And we'll give everyone just a couple of minutes. I know there's lots to think about and kind of new territory and new information to take in. We do hope that you find the presentations helpful to go back and reference should some questions arise. And again, always feel free to email either Shelby Hornback, Elizabeth Burrows, or I. This is Becky Royer with questions, and we'll help facilitate and answer. And Ashley did just share in chat, she did not hear anything regarding CR modifier.
Oh, I think we're going to focus on yes. And I also just want to share a best practice. I think that I've got a couple hospitals working on this is a time to get annual wellness visits in. It's a time to get some of those visits that maybe you don't have time for otherwise. If you're, I mean, literally I've heard, I know everybody, it's COVID, and all the providers are so busy. I've also heard the other side that we've got people in clinics sitting around because you know, your quote unquote normal patients or your chronic care patients are scared to come in. So this is a time with these relaxed regulations to get some of those visits to recoup some of the lost revenue. So if you happen to be working on getting some of your annual wellness visits in, if you would let one of us know, that would be great, because I've got a couple hospitals just starting that process and they would love to learn from you. I also know we have some hospitals that are unveiling their behavioral health services, and they've been doing behavioral health visits just starting, but they've been doing them via telehealth, and that's been a huge success and great for their patients and even the staff that are also patients. So again, I've heard some telehealth success stories. We would love to hear more. And if you would even let us know for that so we can highlight some of those great things that you guys are doing. that would be helpful. I also want to say it's great that we have such a good friend with Indiana FSSA. So Elizabeth, we really thank you for your time and being able to answer questions. So a question came up, suggestions on how to do an annual wellness check with telehealth. I have not personally seen them, but again, it's just using the video, it's going through the questions. They were talking about working through and having a nurse go through certain questions, the provider do their questions and their assessments. So that's how I know two sets of clinics are doing it. If we do have interest, that may be something we can host, just kind of a joint call with a few hospitals. So if you are interested in that, let Becky, Shelby, or I know, and we can try to get that arranged. But again, I think it's just traditional telehealth. I know I've personally had physical therapy visits via telehealth that I thought, how is this ever going to work? And it was very, very good for me. So, yeah, just thinking outside the box.
Elizabeth, I did receive a question. Is there a list of standard questions that you could share for the wellness visits?
Sure, we could probably get our hands on that. It's just the traditional CMS Medicare guidelines, but yes, we can include that in the email that we send out. But again, it's just, if you've been doing annual wellness visits, like Diana Perry has done hundreds of them last summer, it's that same list. But again, just thinking outside the box and okay, this may be a good time where people do have time to answer all those questions and go through that visit. But those can all be found on the CMS website. We can send those out as well.
Great, thank you.
Well, thank you.
Any
everyone.
other questions? We do have a question that came in. In providing behavioral health during this time, I've been able to warm handoffs via telehealth with the provider in my clinic. And that's just a statement, yes. That's wonderful that you're incorporating that. Thank you for sharing.
And I know that works because that particular provider is at the office with the other providers, so they can do warm handoffs right there. You know, you're carrying the screen, the iPad. So again, I love how creative and brilliant all of you are during this difficult time.
Any other questions or sharing? Feel free to chat. We're very, very open and really appreciate all the input you can provide. And we do have one at Putnam County Hospital. We are performing telehealth in our RHCs and behavioral health clinic. It's been a wonderful success. Happy to help anyone with questions. Thank you, Morgan. Very much appreciated. And great that you're having great success. Anything else? Well, again, we appreciate everyone joining today. We hope you found the information helpful. We will clarify the questions that have come up during the call. And wishing all of you well and safety. We will send out the presentation, the recording link, the answers to the questions all together, as long as the email contact information, that as you're working along and questions arise, we will do our best to get the answers back to you as quickly and as efficiently as possible. So have a wonderful day, everyone. Thank you so much.